Good evening, everyone. Welcome to the Masterclass in Critical Care Medicine from Yashoda Hospitals and IDCCM Hyderabad chapter. Today's session is Acute Exacerbation of COPD case discussion. We have senior consultants, Dr. Vijai Kumar sir from Apollo Hospitals as senior examiner, and another senior consultant, Dr. Mohan Maharaj, Director of Critical Care Medicine, Head of Academics, Medicover Hospital, Vizag. They are chairing the session, and the students who are going to present the case is Dr. Anudeep and Dr. Ganesh from Care Hospitals, Banjarahills. Anudeep, you can start the case.
Dr. Sasi, I think Dr. Vijai Kumar sir has been a faculty for all the good set of medical colleges and big organizations in Hyderabad. Right now, I think he now more focuses in his own clinic and a setup where he actually enjoying his outpatient-based treatment, and also a setup where he actually deals with a multimodality investigation. So, am I right, sir?
Yes.
No more
yes,
associated with Apollo Hospitals right now.
No more, correct. Absolutely.
But he was a part of all the big organizations, including Apollo, Yashoda, and all, for a long period of time, including the Nizam's Institute of Medical Sciences.
Most of all, I enjoyed my stint in Yashoda Hospital because that is where I grew, and also I could see Yashoda grew as far as the pulmonary medicine was concerned.
Thank you, sir. Thank you.
Anudeep, you can start the case.
Yes. So, good evening, sir. Screen, sir. So, 55-year-old male, resident of Banjarahills, Hyderabad, and he's a businessman by professional, presented with cough with expectoration since 10 days, and fever since 5 days, and shortness of breath since 2 days. Next slide. In history of present illness, patient having cough with expectoration since 10 days, which was a copious amount and yellowish, yellow mucoid sputum, which is not foul smelling or bloody sputum. And patient is having history of fever since 5 days, which is intermittent and low grade in nature and not associated with chills, and there is no diurnal variation. And history of shortness of breath since 2 days, and which was aggravated with mild activity and lying down. And patient was on 1 liter of home oxygen, which was increased gradually to 6 liters since 2 days, and associated with wheeze more in the morning and subsided on nebulizations at home. There is no history of chest pain, palpitations, excessive sweating, decreased urine output, swelling of feet, burning micturition, and abdominal discomfort. In the past history, patient is a known COPD since 10 years on minimal oxygen support of 1 liter since 3 years, and also he is on nebulization therapy. And the history of similar complaints in the past and associated with 2 to 3 hospital admission per year in last 3 years. And he is known diabetic and hypertensive. For hypertensive, he's on amlodipine, and for diabetes, he's on metformin 500 mg BD.
Vijay Kumar sir, you wanted to stop in between and ask, or go till the diagnosis and go ahead? What is the plan?
I think it is better to stop and interrupt.
Yeah, please.
Because
true. At each step, I think we will stop and probably we will interact.
Yeah, there is a lot of questions what we
correct. Yeah, Anudeep, one thing you did not mention, because we are dealing with a patient who is labeled as COPD. Somebody has labeled, but we need to know whether he is a smoker or not. And if he is a smoker, how many cigarettes per day, how many years?
So next slide.
It's coming?
Yes,
okay.
Yes.
And before that, Anudeep, just one thing, that even we're looking at the symptoms, how do you go for a differential diagnosis of, or at least what are the things we can get into the mind? Because we already know that this is a COPD patient, I agree on it. But
Yes,
looking at the symptoms, and if you see as per our clinical Hutchinson or Macleod's, when you go, how you actually think a thought process you have?
Sir, patient is having cough, SOB, and fever, sir. So my differential diagnosis are any community acquired pneumonia, and bronchial asthma, any acute exertion of bronchial asthma, any aspiration pneumonia, any pulmonary infarction, or any tuberculosis, and any pneumonitis, hepatitis pneumonitis. These are all
Okay.
differential diagnosis.
Okay,
And
we'll take up.
also, sir.
Let us first, please tell us why it is not community-acquired pneumonia. What is against community-acquired pneumonia?
So it can be community-acquired pneumonia. Maybe patient having fever, it can be an infective exacerbation of COPD also. Can be community-acquired pneumonia also can be this. And in COPD, the main presenting complaint will be the SOB, sir. In community-acquired pneumonia, fever and cough.
In COPD, cough and expectoration. In
COPD
addition to
main
shortness
complaint
of
will be,
breath.
yes, sir, cough and expectoration. The patient will be having long-standing cough, sir. Along with the main complaint will be the SOB, sir, in COPD.
But here he has an exacerbation. No? He
Yes,
has
sir.
COPD all along, but now last 10 days, let us say that he has got an exacerbation. And that is why he has got cough, expectoration, and increase in shortness of breath. Did you come?
Yes.
Did you hear about Antonician's criteria?
No.
Yeah. Maybe you should go back and read what is Antonician's criteria and what is its relationship with the exacerbation of COPD. They come very close to each other as far as the definition is concerned.
And as you said, history-wise in the fever, if the fever is having with the chills or without chills, how you are going to differentiate? What is it you can think about?
Fever with chills means a high-grade fever. Patient will be having high-grade fever, and probably we can think of infection. Yes, sir.
Yeah. Sure. Go ahead. I think we have Vijai Kumar sir. We have total duration of 1 hour time, so we need to complete also, I think.
Yeah, correct. I know.
Sure. Go ahead, please.
In personal history, patient is having sleep disturbed and appetite decreased, and bowel and bladder movements are regular and mixed diet. Patient is having history of smoking 10 cigarettes per day since 30 years, and last smoked was 3 years back, sir. And
So he stopped smoking.
3
yes,
years
sir.
back.
He stopped 3 years back. He stopped smoking. And shall I go ahead, sir?
Yeah, please.
Yes. On arrival to the emergency department, initial examination, patient having poor general condition and cacaxic, and he is drowsy, arousable, and obeying commands, and tachypneic and unable to complete the sentences. And on general examination, patient is having mild pedal edema. There is no pallor clubbing, icterus or cyanosis, and his pulse rate was 110 per minute and BP 110/70. And SpO2 of 70% in room air, and respiratory rate of 40 per minute, and he is febrile, temperature of 101 degrees Fahrenheit. And
what are the things gives us for the seriousness, and if you look at the criteria, the scoring system, what are the things you look at it?
yes, sir. Dyspnea at rest, or
The grading of dyspnea, yeah.
Count MMRC score will be score of 0 on a strenuous exercise, and score of 1 during vigorous exercise, and score of 2 with the patient contemporary age group. Patient is unable to walk at the same rate, and he will be stopping intermittently. And score of stage 3, patient cannot walk more than 100 yards, and score of 4, patient having dyspnea during dressing, undressing, and during a rest also having score of 4. And MMRC grade 1 and 2, 0, 1, 2 is a mild, and 2, 3 greater than or equal to 3 is a severe. And history of number of hospitalizations, and previous history of hospitalization requiring ICU admission more than 1 or more than 2 exacerbations per year, or baseline respiratory rate, baseline sensorium. We can know the status of the patient already having syncope while having cough, and patient having pulmonary cachexia. These are the severe signs of COPD.
Okay, Ganesh, you start. Anudeep, okay, go ahead.
On systemic examination in respiratory system, on inspection, patient is having a barrel-shaped chest and using accessory muscles for respiration, and there is bilateral chest movement was decreased, and percussion, there is a resonant note, and bilateral lung fields, and auscultation, there is bilateral vascular breath sounds and a decreased intensity in both sides, and bilateral polyphonic waves and bilateral basal coarse crepitations were present. And CVS, there are S1, S2 are heard, tachycardia present, no murmurs heard. There is raised JVP, can be observed, and abdomen soft, non-tender, and no organomegaly. CNS, patient is drowsy, irascible, no focal neurological deficits, and GCS of 14/15.
What's your impression looking at all these things?
Yes, sir. Patient is a known COPD, presented with cough with expectoration and SOB and fever. So my first on examination, patient is having a tachycardia, hypoxia, and bilateral basal coarse crepitations and bilateral polyphonic wheeze, raised JVP. So my diagnosis will be acute exertion of COPD with probably any car pulmonary.
You already diagnosed with the cough pulmonary. Okay, you said the cough is there. No, duration of the cough was
10 days, sir. 10 days.
So when do you say acute or chronic? What is the duration? You call it as a cough duration. You have a chronic cough or acute cough.
More than 2 weeks. Chronic.
Ganesh?
So cough more than 2 weeks, sir. That's
3
cough
weeks.
chronic.
Please understand, if it is less than 3 weeks, it is acute cough. It is more than 8 weeks, it is called chronic cough. Okay, next. So just go back to the slide. Yeah, here you have been said, Vijay Kumar sir, please, I want more about the shape of the chest and the percussion, resonate little more into that clinically.
Yeah, percussion, you said there is resonant note.
Yeah.
Yes,
Is
sir.
that so? Yeah.
Yes.
And vesicular breath sounds with decreased intensity and also polyphonic wheeze.
Yes,
Do
sir.
you expect polyphonic wheeze in COPD patients?
Actually, polyphonic wheeze is due to multiple bronchospasm, sir. Bronchospasm at multiple levels.
So what we say is we call it as rhonchi, scattered rhonchi both sides. Usually polyphonic wheeze is seen mostly in asthma. Can COPD and asthma coexist?
Patient of bronchial asthma having exposure to smoking and environmental pollutants can have this overlap.
Can have.
COPD asthma.
Anyway, we stopped calling asthma as bronchial asthma because long time back there was cardiac asthma, so we had to call bronchial asthma. But now there is only one asthma. You see any textbook, any article, you will see only the word asthma. Nobody uses bronchial asthma. Even for diagnosis, when you write in the case sheets, avoid bronchial and just write asthma. And yes, asthma and COPD can coexist. It is called asthma COPD overlap syndrome. Now it is called ACO, asthma COPD overlap. So they can coexist. Yeah, go ahead. And in the abdomen, usually a patient of this nature will have certain amount of engorgement of the liver. So you will see some tenderness in the right hypochondria.
Yes.
Along with pedal edema and raised JVP, which signifies that there is an increased pressure in the right heart.
Okay.
One small thing, either Ganesh or Anudeep, as sir was
Sir.
talking about ACO. So in the ACO, when you're looking at the age-wise or we're looking at the patient, how do you differentiate as per the history and as per the systemic examination, how you are going to differentiate as per this one, whether ASO, ACO, or it's only the asthma examination or COPD long standing? What are the things you look for? What are the differences?
Asthma patients usually seen in less than 20 years. COPD patient will be having more than 40 years. And COPD patient will have baseline symptoms, and during acute exacerbation, they will be having worsening symptoms. And because of chronic increased work of breathing, they will be having dynamic hyperinflation that cause barrel-shaped chest. And because of work of breathing, they will be having malnourished and barrel-shaped chest and indrawing of lower coastal muscles we can see in these COPD patients. And the symptoms.
The past history will be there.
Yes, and symptoms, PFTs won't normalize in between the attacks in COPD, but in the case of asthma, we can see a patient may have a symptomatic period in between the attack, and normalization of PFTs can occur in the asthma patient, whereas in COPD doesn't occur in the.
As we are not come to the investigations, we'll just talk about only up to this systemic examination, what the difference is. What is the duration, like a time course, which will be progressive, which will have which is spontaneously and triggering factors are there for this asthma, whereas COPD, that's not like that. And as you said already, exacerbations, it is there, and the treatment is there since long time, and which is reduced. And airway inflammation more, right? That will come to the investigation side. Okay.
And asthma patients will be responsible to the steroids, and COPD patient doesn't respond to the bronchodilators. They have very less response.
But do you give COPD steroids? I don't give.
We'll be giving steroids in acute exacerbation.
Right. Sure. And any, okay, that we'll talk about the functions. Okay, next. Anything else? Vijai Kumar sir, shall we further?
Yeah,
proceed?
we'll proceed.
Yeah.
So, provisional diagnosis is acute infective exertion of COPD with suspecting carpulmonary. And next slide. So, patient was in emergency department.
As you diagnosed as a COPD, do you have any clinical severity of the COPD? Anything is there?
Yes, sir. COPD. COPD.
What is actually definition of ACOPD?
Sir, acute COPD is a acute onset of sustained worsening of stable state with change in normal variations, normal variation in respiratory physiology, and requiring treatment in a patient of known COPD.
What are the three cardinal important things to say that it's acute exacerbation COPD? I repeat it again. One is you said dyspnea, then
cough and sputum, and increase in oxygen requirement, and which needs change in medication for these patients.
next, go ahead.
So, in patient airway breathing circulation was managed.
Shall we proceed now, Vijay Kumar sir?
Yeah, please.
In airway patient is having a patent airway, and in breathing.
Are we not going to look at the investigations now? X-ray, CT scan.
Yes, sir. This is in the year, sir.
Spirometry done
emergency
before.
Department. Yes, okay, agreed.
Yeah, done before. Patient must be having records of spirometry, X-ray, CT scan.
Past history.
Because he has been using oxygen for the last 10 years.
Slides are not.
Okay. Anyway, it is very important to look at the old records of such patients because he's on oxygen at home and he has been using oxygen for a long time. So he must be having records of X-ray, CT scan, and also the spirometry. Spirometry will tell us what Dr. Mohan Maharaj was saying about the severity of the COPD.
Yes,
looking at the FEV1.
So his CT showing bilateral paraseptal emphysematic changes, peripheral bullae were there, sir. Diffuse peripheral bullae were there, sir, in his CT.
Why is the CT scan so important for treatment?
We can differentiate other causes of the respiratory failure. We can rule out other causes, and any chances of pneumothorax. If there are large bullae involving more than one side of the lung, there are chances of pneumothorax, and there will be respiratory compromise will be there. And exercise, we can treatment, sir. Any bullae resection, lung volume reduction surgery we can perform to improve the morbidity.
It also helps you. It also helps you to select the antibiotic, because if the patient has structural lung disease, then little rarer organisms like Pseudomonas are expected. But if there are no structural lung disease, maybe just community organisms will be there. So community-related antibiotic should be enough. It helps us to select the antibiotic.
Yes, sir.
Okay. Spirometry not available, no?
Yes, sir. In view of hypoxia, patient was initiated on oxygen support in the emergency department, and nebulations with salbutamol 10 mg and ipratropium 2.5 mg and budesonide given, and empirical antibiotic. We are suspecting infective exacerbation, so empirical antibiotic with piperacillin tazobactam and clarithromycin. Piperacillin tazobactam 4.5 grams stat and clarithromycin 500 mg IV given, and systemic steroids were started, and for temperature control antipyretics with 1 gram of paracetamol given, and initial ABG showed pH of 7.
Just one comment. Is there a better drug than ipratropium? What is ipratropium?
Short-acting antimuscarinic.
Antimuscarinic agent. Is
Yes.
there anything new which is available?
Yes,
Glycopyrronium. Glycopyrronium is available, which is even far superior, and it has got a long duration of action. And even salbutamol has been replaced by formoterol, because formoterol also has a very rapid action and also a long duration of action. So when you use these two, you may not have to really give very frequently, and that reduces the burden on the nursing staff, and patient gets good benefit.
Yes.
Budesonide is questionable, because unless you make a diagnosis of asthma, budesonide in acute exacerbation of COPD may not have a big role.
Yes, it prevents exacerbations, not for.
Yeah, maybe during discharge, depending upon his spirometry. Again, here spirometry is very useful. Now there are very clear-cut indications for budesonide in COPD cases. So frequency of exacerbations, hospitalization, and FEV1 very low. So now COPD is classified into A, B, C, D, 4 boxes. So if he falls into the D box, then budesonide is initiated. Otherwise, no, should not be given.
Anyway, coming to this, Ganesh, as you said, the first slide view of hypoxia initiated oxygen support. So what are the targets of oxygen therapy, oxygen support in emergency department? How do you approach it scaling wise?
So we have to target a saturation of 88 to 92%. Sir. If you target saturation of more than 92 or higher amount of oxygen, it will damage the HPV axis, and there will be more amount of CO2 retention. It can further worsen the CO2. Sir. So we have to target a saturation of 88 to 92. So PaO2 of around 60 to 70 is sufficient. And
Hypoxic,
better to use
hypoxic drive is knocked out.
yes, sir. Yes, sir. Fixed devices like Venturi and HFNC you can try. In milder cases, like pH is more than 7.35. If pH is less than 7.35, you have to try NIV with inhalational bronchodilators.
As you said, the nebulization of solvent one, what is the dose you give, how you give, what is the best method of nebulization? Because you know, what are the 4 types of nebulizers available with them?
Jet nebulizers, ultrasonic nebulizers, and
Mesh
mesh
nebulization and pressurized metadose inhaler. Pressurized metadose inhaler has a better effect. And in case of NIV, we have to use that nebulization as near to the NIV face mask. Whereas if you keep on ventilator support, better to go away from the patient towards the ventilator, better to connect, because it delivers more amount of drug to the patient.
No, sir is asking about what are the different nebulizers available and which is the most popular one which all of us use in our units.
And second thing is, if you are using ultrasonic, what is the method it's using? Is it going to be what is important, how it's going to work? That's all.
Sir, we commonly use jet nebulizers, sir, and the ultrasonic nebulizers they use piezoelectric signals, sir. They because of the vibrations, there will be generation of aerosols.
Is it the particle size is more important?
Yes,
less
sir.
than 5 microns.
We target 1 to 3 microns, sir, for delivery of aerosol.
You're using, as you said, Ganesh was talking about use more of jet nebulization, right? Is it more beneficial? Ultrasonic is more beneficial.
So jet has more beneficial because amount of drug delivered is more compared to the ultrasonic.
But when you're using the ultrasonic, it passes in the same level, and the micro that particle levels reaches there to all the areas. Vijay Kumar sir, you agree with that?
Yeah, correct. So the ideal particle size should be 2.5 so that it gets deposited in the small airways. If it is even smaller than that, what happens is it goes into the alveoli where it is not required. And if it is too big, then it gets deposited in the major airways. So you need to have a particle size majority, at least 50% of the nebulized material should be of 2.5 size. So the metadose inhaler, etc., we are not discussing right now, because that's when we come to the maintenance therapy. Of course, we start using metadose inhaler. But in the ICUs, in the hospital, nebulizers are preferred because we know that this patient is slightly drowsy, although arousable. So such patients, it is difficult to give them metadose inhaler with spacer. And nebulization should be given through the mouthpiece rather than with a mask. If the patient can inhale, a mask should be avoided and a mouthpiece should be given. That way, maximum amount of nebulized medicine will get into the lungs.
Yes.
As Vijay Kumar was talking about FE1 ratio, right? The predicted value in the history when you were talking about to make it a severity. So there is a grade 1, grade 2, grade 3, grade 4. How much it is if FE1 comes percentage? Ganesh?
Mild means more than 80, sir, and moderate 80 to 50, severe 50 to 30, and less than 30 is very severe. And FE1 by FEC always less than 70. And if you use this criteria, milder symptoms we cannot detect properly, sir. That is a drawback. So we had a newest course, COPD assessment tool. That is the criteria we are using for severity grading now.
Right. So Anudeep, what
Sir.
is the reason you selected piperacillin and tazobactam?
Sir, patient is having previous hospital admissions, and recently also he admitted, and also he is having structural lung disease. So
Recent means how recent? What does the literature say? In the previous
recent means,
how many weeks?
yes, sir. More than 2 days of hospitalization for in last 90 days, and history of antibiotic use in last 3 months, and malnourishment and alcoholic and immunocompromised. These cases we suspect Pseudomonas.
Correct. But this patient, was he admitted in the previous 3 months?
Yes, sir. Yes, sir. He is having admission 3 admissions in every year, and last 3 months also he got admitted.
So there is one reason, and the other reason should be, as I said, structural lung disease. What is the basis for clarithromycin?
Clarithromycin we give for atypical coverage, sir. Atypical organisms to coverage.
Our atypical organisms.
Yes.
What are they?
Mycoplasma, chlamydia, Legionella.
Good, very good. Okay. Any choice in systemic steroids?
Prednisolone 40 to 60 mg, most preferred drugs.
Which one?
Sir, studies was done on more on prednisolone, sir. 40 to 60 mg for 5 to 14 days. Prednisolone.
Prednisolone. But you said
Yes,
that means oral or intravenous?
sir, we had supplied with oral, sir. Oral per oral, 40 to 60 mg for 5 to 14 days.
Okay. So should we give intravenous steroids or oral steroid?
Oral preferred, sir. If
Oral
patient
preferred.
is yes, sir. If patient is unable to take, we have to give intravenous.
No, this patient.
Oral.
Oral? You said he is drowsy.
Hypoxia come to ER and drowsy, you told?
Yes, sir.
How can you make him swallow the tablet?
Actually, we gave IV hydrocortisone, sir. IV hydrocortisone 200 mg stat actually.
Afterwards?
Afterwards, 100 mg QID. We have given, sir, for 5 days. Later, stop.
Stop.
Yes, sir.
Should we give only for 5 days or should we give it for 14 days?
5 days. There is no difference between 5 days and 14 days, sir. 5 days.
If he's improving.
Okay, sir. Yes, sir. If he's improved,
Yeah,
5 days.
that's true. So, as I said before the steroids, as I said, macrolides has some advantages. What are the advantages of macrolides?
It has some anti-inflammatory effects, sir.
Huh?
So it has some anti-inflammatory effect. So it can prevent exacerbations.
Antibacterial, anti-inflammatory, and immunomodulator effect. Fine. Next.
There is a question here. Is oral corticosteroid better? So it is not better. It actually says oral corticosteroids and intravenous corticosteroids have got similar response. If the patient is drowsy, we go for intravenous. If the patient is not drowsy but able to sit, swallow, then we can give oral. There is no difference between oral and IV. That is what the literature says. And the basis for giving steroids for only 5 days is the study which was published in JAMA in 2013. The study called REDUCE trial, where they gave it only for 5 days in comparison to 8 days and 14 days. They found the response is very similar. So that's the reason why we stop short after 5 days. Do we have to give intravenous all the 5 days?
No, if patient is improving, if we're able to take, we can switch over to oral. Yes.
Any preference between methylprednisolone and hydrocortisone?
No, both can be used, sir. No, there is no preference.
Similar action.
Similar.
Agreed.
Go ahead, please. So
So
we have come to the ABG.
yes.
Do you have a preference of antipyretics, or when do you give antipyretics? What is the advantage of it and why?
Antipyretic patient is fever can cause increase oxygen consumption and increase CO2 production.
One.
So and
What will happen to the consumption, metabolic rate, and as you said
Yes, sir.
rightly, if we in what we have the thought process regarding the sepsis also.
yes, decrease oxygen consumption will be decreased and CO2 production also decreases. Yes.
So you have any choice of antipyretics, or just paracetamol sufficient? You give the dose so much?
Those 1 gram TIDs.
Any age, any weight, anybody say 1 gram? How we give for
Yes.
ICS?
10 mg per kg body weight.
10 mg per kg.
Right. Go next.
Patient initial ABG showed a pH of 7.23 and PCO2 of 81.5 and PaO2 of 82 and bicarb of 33.9 and saturations of 90% on 10 liters of oxygen. And after initial supportive treatment, patient having worsening respiratory distress and he was tachypneic. So
No, you
in
don't
view of-
want to interpret the ABG. What does it say?
So in the ABG, there is pH is showing acidosis of 7.23 and PCO2 of 81.5, CO2 raised, and bicarb of 33.9.
So what is it? What is your inference?
There is a respiratory acidosis with metabolic alkalosis, non-compensatory metabolic alkalosis.
Uncompensatory.
Why can't it be chronic respiratory acidosis?
It is.
Is there any formula to check?
Yes, sir. Point for acute, it is 0.08 into PCO2 minus 40 by 10. For chronic, it is 0.03 into PCO2 minus 40 by 10. For acute and chronic, for respiratory acidosis less than 24, we have to see the compensation of bicarb. For 10 for any raise in 10 mmHg of CO2, there will be in acute 1 change of bicarb. In chronic, it is 4 change of bicarb.
So here, if you take PSCO2 40 normal, here it is 81. So if it is chronic, how much change should be there in the bicarbonate?
If it is a chronic, 12, sir. 16. 16.
16?
Yes, sir.
Okay. So what is the normal HCO3?
24, sir.
24.
22 to 26.
22 to 26, which we take is at 24.
Okay. So here it is 34. Do you think it is compensated?
No, sir, non-compensatory.
So what do you say?
It's a case of
because he has been having the symptoms for the last 10 days.
yes,
He has
sir.
been hypoxic for 10 days. He has been gathering carbon dioxide for the last 10 days. So I say that this blood sample taken for ABG is wrong. How do you check it? Whether it is a good sample, whether it is a
Validation
venous sample,
calculation.
how do you validate the ABG?
24 into PCO2 by bicarb we take, sir. We get H plus value.
Right.
We
80
take the
minus-
value 80 minus the obtained value.
80 minus
80 minus the value 24 minus 24 into PCO2 by bicarb.
80 minus the last 2 digits of pH should be equal to this value. Whatever value we get by doing the calculation of 24 into PCO2 by bicarbonates, that value should be equal to 80 minus last 2 digits of the pH that you have here.
Yes, sir.
So anyway, before do interpretation of the ABG, we have to do this particular calculation. What is this calculation known as?
Validity of pH.
Is the Henderson-Hasselbalch equation.
Okay.
Right. Somebody wanted to repeat the formula. It is hydrogen ions equal to 24 into PCO2 by bicarbonates. And whatever product you get it should be equal to 80 minus last 2 digits of the pH that you have in your report. So then we can say that this is a validated ABG. And then, of course, you have to use the compensatory formulae. Short form is 1425, that is 1 for 10, 4 for 10, 2 for 10, 5 for 10, for acute respiratory acidosis, chronic respiratory acidosis, and acute alkalosis, and respiratory alkalosis, and chronic respiratory alkalosis. So then, of course, for metabolic acidosis, you have a different form. It is 1.5 into 8, 1.5 multiplied plus 8. Okay. We'll not
Otherwise,
go
you
into
should
that.
recalibrate the machine and you should redo it, and then only you have to evaluate and diagnose.
Okay. So what is the significance of 7.23 pH in this particular patient?
Yes,
What
sir.
does it tell us? What should we do?
pH of less than 7.25 and PCO2 of more than 60, sorry, more than 45 indicates life-threatening acute exacerbation of
Correct.
COPD, sir.
So what do we do?
So,
This will give trial of NIV, sir, and we will observe the
after
patient.
supported treatment,
As first he said hypoxia oxygen support started. Ganesh, you were telling about, no, what is the, if you see what is the preferred oxygen therapy as per the level of, as you're telling, no, you go for venturi mask first, then go for, there's a clear cut method, which one is the first, which one is the next, and what level of liters of oxygen you go for the further higher escalation. Is there, no, Ganesh?
Yes, sir. First venturi will try, sir.
Yeah.
First, fixed devices you have to use, sir. Fixed oxygen delivery agents you have to use. So venturi will be
Venturi mask, then go for nasal.
HFNC.
Yeah.
The patient after 1 hour and with
Before HSC, you go for non-deep breathing mask,
yes.
because you go for first venturi mask, then go for nasal cannula, then go for a fixed FiO2, higher FiO2, then go for the non-deep breathing mask, then go for a HFNC. Okay.
In acute exacerbation of COPD, oxygen is not a big issue.
Yeah.
You can simply correct the oxygen with either nasal cannula or a venturi mask. The issue is carbon dioxide. And that's the reason why the pH is so low, 7.23. And you have to immediately run for the NIV. So the guideline says start NIV. So, sorry, yeah.
Yeah, go ahead, sir, because we have a
Yes, Dr. Mohan.
guideline is there, GINA guideline is there, no? Yeah.
Yes, old guidelines and also FCCP guidelines.
GINA.
So NIV GINA guidelines mostly deal with asthma, and gold guidelines mostly deal with COPD.
COPD.
And they have clubbed them together for acute exacerbation in the ATS and ACCP guidelines. So are there any studies which says that NIV produces good results? Why should we prefer NIV?
NIV is a grade A recommendation in acute examination COPD, sir.
Right.
And also during weaning for post-extubation trial, we can use NIV for NIV, which is a grade A recommendation. Also cardiogenic pulmonary edema, grade A recommendations.
Yeah.
NIV.
Before the year 2000, when NIVs were not in vogue, we were just intubating these patients and ventilating. Now, after the year 2000, NIVs have become more popular, more studies have come, and they say NIV is better than intubating and ventilating the patient. What is wrong with intubating and ventilation?
With the intubation, chances of hypoxia during intubation, post-intubation hypotension, and infection like VAP, ventilator-associated pneumonia, length of stay, length of hospital stay, all were increasing. That can be avoided with the NIV.
Just before that, as Vijay Kumar is telling you that there's no much role of non-rebreathing mask, okay? But at the same time, if you understand pathophysiology, I think Ganesh, you can tell about what is actually pathophysiology. So then what Vijay Kumar sir said becomes easy to get it.
Sir, in COPD, there will be dynamic hyperinflation, sir, because of resistance of the distal airways, that is less than 2 mm diameter, and as well as airway collapse in emphysema. As you can see, both the pictures in the, and because of airway collapse, their patients can have chance of development
increase in
of
airway resistance. Okay.
yes, airway resistance.
Increase in work
chronic
of breathing
bronchitis,
because
increase in work of breathing, sir, because they develop intrinsic PEEP. In order to counteract the intrinsic PEEP, they will be have to trigger against the intrinsic PEEP, and they have to initiate the breath. So they will be having more work of breathing, and there will be, because of hypoxia and hypercapnia also, there will be more work of breathing, and because of hyperinflation also there will be increase in intrathoracic pressure. Because of intrathoracic pressure, there is less venous return and low cardiac output, and further hypotension and increased work of breathing, and compliance also decrease in the disease.
reduction
So
of compliance because of hyperinflation as well.
yes, sir. All these factors cause increase the work of breathing in these patients.
Okay, at what stage you decide that this patient should be put on NIV? What are the deciding factors?
Based on the subjective and objective, sir. Subjective factor, increased work of breathing, increased respiratory rate, and severe hypoxia, PaO2 less than 40, and objective criteria pH of less than 7.35 or less, with PaCO2 more than 45, and the patient developing
7.35.
Yes, sir.
7.2.
What is the normal pH?
7.35 to 7.45.
Correct.
And
So
we are telling normal only, no?
Sir,
7.25.
7.25 will mostly initiate the ventilator support, sir. First, mild, moderate, severe. So mild is 7.35 more than pH, and moderate means 7.35 to 7.3, and less than 7.3 severe. Mostly in the mild, there is no role of NIV. In moderate to severe, there is a role of NIV. Mostly in severe patients, there will be highly 50% will go on ventilator support. So pH 7.35 less with PaCO2 more than 45, we have to insert the NIV after 1 hour with the oxygen.
7.3 to 7.35 as per up to date, but normally it is before that only we start.
Okay.
And clinically, as you said, talking about the lethargy, axillary muscles are working, and cyanosis less than SpO2 88% and having a difficulty, then you have to start NIV as per the guidelines. Am I right, Vijay Kumar sir?
yeah, 7.30. If you want a gold medal, you will have to mention the 2 landmark studies which have used NIV and said NIV is wonderful? What are the two landmark studies? Okay, one study was done by Brochard. It's a smaller group of some 50 patients. But then a few years later, Plant, his name is Plant, he did a study of a larger number of patients, COPD, acute exacerbation. And he said clearly, it reduces the mortality, it reduces the need for intubation and ventilation, it reduces the length of stay in the hospital, it reduces the length of stay in the ICU. So based on these two studies, we have started using NIV very aggressively. And they said 7.30 is the time because they used pH as a pointer. So they use 7.30. But practically we have used for patients who were brought to the emergency whose pH was 7.2 or even 7.1, they survived with NIV. So it is all experience and familiarity with the NIV. That's very important. So when you say that NIV is successful, when you say that okay, he is getting better or he is not getting better?
Again, subjective and objective criteria. Subjective, patient is improving, that is respiratory distress is decreased, and patient sensorium got improved, and workout breathing got decreases, and tachycardia got settled down, and pH got improved with a drop in PSCO2. These are the criteria for NIV, that NIV is successful for the patient.
After how many minutes after starting NIV?
We will observe for 2 hours. We'll observe
1 to 2.
1 to 2 hours, yeah.
1 to 2 hours.
So pH should get normalized and CO2 should start decreasing. These are the two very important things that we are looking at the ABG, apart from the subjective things, right? Which mask you would prefer, a nasal mask or a oro-nasal mask, facial mask?
Oro-nasal mask.
Why?
Because
PEEP can be effectively delivered, sir. In case of nasal mask, if the patient keeps open mouth, high chance of PEEP will be lost. And
or a leak will be
leak will be more.
So the latest NIV machines can compensate the leak, but it can compensate only to the extent of 20%. So more than that, it cannot compensate. That's the reason why we have to use a mask which covers both nose and mouth. So even if the patient keeps the mouth open, patient still gets the required amount of volume of air. Okay.
When the patient is in NIV, if we're really comfortable or agitated or driving away pain or anything, do you give any sedation or mild analgesia with mild dose is given?
In our ICUs, in our emergency department, some people use dexamethasone, low dose dexamethasone, and they will be avoiding opioids. Mostly
because there is a almost prospective study is there which actually says it increases a 5-fold failure of NIV when you are using the sedation and analgesia.
And then when you are putting the mask on the patient, there is a 2-finger rule. Have you heard about it? Okay, when you tighten the mask with the straps, the frequent complication that happens is at the bridge of the nose. The mask will produce pressure and there is excoriation and there can be an ulcer, necrotizing ulcer. So very common thing. So you should not tighten the mask too much. So what you do is you put 2 fingers at the forehead between the mask and the patient's skin and then gently tighten the mask. So this will tell us that the mask is not too tight. So this is called the 2-finger rule. And then use the mask. And or you can even put a small patch of deodorm that will also protect the skin. But the best is not to tighten it too much. The more you tighten it, because the mask is a silicone mask, it will go into folds. And when it gets into folds, then there is a more air leak, right? So we have put the patient on NIV, and 2 hours later, we repeat the ABG to see whether it's getting better or not. Okay. Then what?
We have to see whether there is an improvement in clinical condition and improvement in ABG. We have to see, sir, any decrease in respiratory rate, decrease in PCO2, and a normalization of pH. We have to see, sir.
Somebody asked, what are the 2 studies which said that NIV is better than invasive ventilation? One is, the author name is Brochard, and the second study is by Plant, P-L-A-N-T, Plant. I think both of them were published in New England Journal of Medicine. I'm not sure about the year.
It's 1995.
Brochard was the first one, and Plant is the second one.
Brochard was in 1995 in NEJM.
Wonderful. So now the golden question is, when you put the NIV, what are the pressures you select? Understandably, it will be a BiPAP, is it not?
Yes.
Bi-level positive airway pressure. So what are the pressure you would select?
So first, I will initiate with EPAP of 1 to 2 centimeters and IPAP of 6 to 8 centimeters. And
Sorry.
target...
Say it again, Anudeep. Your microphone is
No,
not
Ganesh
able
is
to hear.
speaking.
Hello, sir.
Yeah.
Ganesh is speaking, sir.
We'll
Little louder.
initiate with EPAP of 1 to 2 centimeters, sir, and IPAP
Okay.
of 6 to 8 centimeters, and
Okay.
target tidal volume of 6 to 8 ml per kg body weight. With respiratory rate target less than 25. So we will increase the EPAP, sir, so that until the patient get comfortable. Until the patient get comfortable, we increase the EPAP slowly 1 centimeter like that. And maximum, we have to keep the difference between IPAP versus EPAP of around 4 centimeters of water. And airway pressure should be less than 20 centimeters in this patient. We have to slowly increase the EPAP. Slowly increase the EPAP. We have to observe the patient whether at what
You
level
said
of
minimum,
EPAP.
the difference between the IPAP and EPAP should be maximum 6 or 4,
8.
something you said.
Maximum 8, sir, minimum of 4.
Maximum 8. It should not be
Yes,
more
sir.
than that.
Maximum of 8 and minimum of 4.
One good thumb rule is EPAP should be 1/3 of the IPAP. Of course, understandably, IPAP should be higher and EPAP should be lower. So EPAP should be 1/3 of the IPAP. So if you put IPAP as 12 centimeters, then EPAP should be 4 centimeters. That's because the difference between the two is the pressure support. And based on the pressure support, the patient will get the tidal volume. And based on the tidal volume, we can calculate the minute volume, because PCO2 washout is dependent upon the minute volume.
One thing, Dr. Ganesh or Anudeep, now as sir was talking about how you set the ventilator, before setting the ventilator, you are shifting the patient to the ICU, right? Because NIV is there. When you shift the patient to the ICU, you talk to the attendants. How do you prognosticate this patient before shifting to the ICU, starting NIV? How do you assess the patient? And how do you prognosticate the patient to the attendants?
Based on the underlying baseline severity of the disease, sir, like gold stage 3, stage 4, or COPD assessment tool of C and BCD, and previous history of hospitalization and cough syncope or underlying comorbid conditions, and all these are the poor risk factors. And FE1 ratio less than 40%, and the change in FE1 volume like 40 ml per kg.
That
And
you
then the
already
patient-
told the seriousness. Now, you have any? Do you have any prognostication scoring system is available?
Sir,
Yes, sir.
for board
Dyspnea.
index is there for prognostication mortality for prognostication, board index like BMI and obstruction
Yeah,
FT1 ratio and exercise
Did you-
intolerance like.
Did you hear anything like decaf or BAP 65 score?
yes, sir.
Yeah, what is it?
DCAF is dyspnea. Dyspnea dependent. Dyspnea 2, sir. One is dependent, one is independent. A is DCAF.
Dyspnea, that's 1 point or 2 points.
Yes,
Then
sir.
eosinophilia, decaf, DECAF, right?
Yes, sir.
E is eosinophilia, because eosinophilia in a lot of studies. You have a sputum eosinophilia, you have the blood eosinophilia. The blood eosinophilia is very high, the risk is high, and EOS is little much higher when you're having both. And C is a consolidation, which is having 1 point, right?
Yes.
Then acidemia. A is acidemia. The pH is less than 7.3. That becomes 1 point. Okay. Then
Fibrillation, atrial fibrillation.
and another atrial fibrillation 1 point. What is okay? Fibrillation. F is fibrillation. Okay. So
Yes.
it is a 0 to 1, it is a low risk, and if it is a 3 to 6, it is high risk.
Yes.
So what is BAP 65 score?
BAP is blood urea nitrogen,
Huh?
altered mental status,
How much it should be
And,
blood urea nitrogen more than
more than 20, sir.
25?
More 25.
Okay, altered mental status.
Altered
then?
mental status, pulse, sir. Pulse more than 100.
More than 100.
And age
Normally
more
in
than
the ICU, you are worried about what rate, particularly for COPD asthma patients, more than 110, right?
Yes, yes, sir.
Okay. Then you have anything? BAP 65, what is it? 65 is age.
Age 60.
Yeah. So what is the
And,
scoring here? How it is?
0 to 1, 2 to 3, more than 3, sir. Low risk, intermittent, high risk.
So this is what
For
you can communicate to the patient. That means looking at evidence, right?
Yes, sir.
Okay. Go ahead, sir.
Yeah, somebody asked about curve 65. Curve 65 is used in relation to the community acquired pneumonias.
And that too to admit or not admit in the ICU,
Yeah.
not for the prognosis.
Yeah, prognosis also.
Yeah, not fully.
And 65 as usual is the age, consciousness, urea, and respiratory rate and blood pressure. So something similar is this for COPD. And somebody asked about the pressure support, EPAP, etc. So the terminology that we use for NIV are IPAP and EPAP. And the difference between IPAP and EPAP is the pressure support. We don't use the term PEEP because PEEP is used only when we intubate and ventilate the patient. Although EPAP is equivalent to PEEP. It does the same thing as PEEP, but we don't call it as a PEEP when we use NIV. That's the only thing that you need to keep in mind. Okay, so when you start removing the NIV, we don't say extubate, but when you start take it off, wean.
Workout breathing is decreased and pH is optimized and sensorium got improved and there is no use of axillary muscles. These are the
when oxygen requirements come down.
Yes, sir. pH to getting improving, pH is getting optimized, and tachycardia, dyspnea, and everything gets settled down.
Importantly, pH should normalize. CO2 takes a little longer time. Bicarbonates will take a little longer time to normalize, especially in chronic respiratory acidosis. Bicarbonates may remain high. It will take some time for it to come down. Have you heard about switch therapy? Switch therapy. It is switching from intravenous to oral medication, as simple as that. It could be switching from intravenous steroids to oral steroids, intravenous antibiotics to oral antibiotics. So we go for switch therapy when the patient is hemodynamically stable, when the blood pressure is normal, when his urine output is good. That means that his perfusion is good in all the tissues. That means his gastric perfusion also is good. So whatever medicine you put in the stomach gets absorbed, and patient should be alert, awake, and should not have any vomitings. Then the patient is fit for switch therapy. By switching IV to oral, you reduce the cost of treatment, and you can shift the patient out of the ICU quickly. And probably you can even discharge the patient if the patient is on oral medications. So you always keep looking for these criteria so that you can hasten up the transfer from ICU to the step down and step down to the house.
So what next? The slide is getting up, yeah.
So after 1 hour, patient respiratory respiratory distress decreased, and his pH was became 7.32 and PCO2 57. He's a little bit comfortable on the NIV, and his work of breathing also decreased. And later patient was shifted to the ICU, and initial blood labs has come, and CBP and showing high total leukocyte count with the neutrophil predominance, and renal function test and liver function tests are within the normal limits, and ECG showing sinus tachycardia with P pulmonale. 2D echo showed dilated right atrium and right ventricle and moderate TR, moderate PAH, grade 1 diastole dysfunction, and good biventricular function. And sputum for gram stain and cultures were sent, which were negative, sterile. An initial chest X-ray showing, next slide. Initial chest X-ray showing there is a barrel-shaped chest and flattening of diaphragm. Flattening of diaphragm and right lower zone haziness in the right lower zone, and tubular heart.
As you're telling the 2D echo, there is a dysfunction, right? Go back.
Yes, sir.
Before the X-ray.
Moderate.
You said RV dysfunction, no? Go back.
RERV dilatation with moderate PAH, sir.
So what is the fluid management in COPD?
Fluid management, actually, they were usually edematous will be there, sir. So, and even our they are edematous and they will not respond properly to our heart-lung interactions. Like we cannot measure our heart-lung interactions properly. So our dynamic variables like PPV and stroke volume variations cannot readily predict the fluid responsiveness.
You get a false positive SCV,
yes,
right?
Yes, sir.
Okay. Okay. Then. Go to previous slide.
No electrolyte imbalance at any time.
Renal function along with serum electrolytes were normal, sir.
Normal.
What do you normally expect?
Sir, patient will be, chronic steroid use can cause hypokalemia and hypernatremia.
So in this investigation, there is no glucose monitoring?
Yes, glucose checked initially, sir, which was normal.
Have you written there in the slides?
No, sir, I didn't.
Yeah, is it not important?
It is important, sir.
There is one thing very important in liver function test, and that is the serum albumin. Because there is one study which looked at only serum albumin, and the patients who did not improve and died, their serum albumin was less than 3. And patients who improved and went home, and their albumin was more than 3. So serum albumin is a very important marker for mortality. keep looking at it in all the studies. So culture, what was the culture like? Pseudomonas?
As you
Actually, cultures were sterile, sir.
Sterile.
Yeah.
Surprising. Because he had fever, leukocytosis.
Maybe
A lot depends upon the sample that is sent.
yes, sir.
If you send only the saliva or the mucus, then you may not get anything. And again, in COPD, acute exacerbation, it is not necessary that always it should be a bacteria. It could be a virus also, in which case you will get a sterile culture. But then, as I said, in most COPD infective cases, you get only the common organisms like Streptococcus, H. influenza, Moraxella catarrhalis. Where there is a structural lung problem, you may get Pseudomonas and Klebsiella.
and in the 2D echo, you said dilated RA-RV, and you previously mentioned one word like core pulmonary, and there is a moderate PAH. How do you assess the like RV dysfunction?
RV dysfunction, like patient will
Very
have
good.
pulmonary hypertension, sir. Pulmonary hypertension more than 25 mmHg.
RV dysfunction are measured by the PA catheter, right?
Yes, sir.
Fine. Normally we don't use it because it's not routinely recommended nowadays, right?
Yes, sir. Right heart catheterization.
Yeah, fine. So, Dr. Shashidhar or Venkat, do we have time still more? Because there's almost another few slides are left still.
Yes, sir. We can continue, sir.
Yeah, thanks. So now the patient is getting, what is the criteria looking for NIV failure, doctor? You say that whenever failure, when is it you say NIV failure?
Patient having increasing drowsiness and persistent PCO2, high PCO2, and respiratory rate of more than 35.
Anything like hemodynamic instability, one of the complications of this which you look for?
Cardiovascular complications, hypotension, shock, previous arrhythmias.
So these are the indications of intubation, right?
1.25.
So how do you prepare for intubation now? So shall I, sir, is it okay, Vijai Kumar, sir?
Yeah, please.
How do you prepare for intubation? What are the things you look for? What is the guidelines? What is it?
Rapid sequence intubation we prefer, sir. And as patient is having moderate PAH, the chances of pulmonary edema during intubations are high. And if there is hypotension, we have to fluid management and vasopressor support we have to keep ready. And
important thing is keeping the vasopressor support and the fluid, both are very crucial.
Yes.
Okay. What drugs you give?
rapid sequence intubation, opioid induction, or we can give if there is no contraindication.
On hemodynamics, sir.
Mostly like what you give? Practically, what are the drugs you give in your ICU for better management? Huh?
Fentanyl, opioid, fentanyl, 2 mics.
You have an induction agent, you have an analgesic agent, you have a sedative agent, you have a relaxant. All 4 are there, no? In that, what is it you are going to do? Preferable for you. What is preferable? Ketamine is preferable.
Yes, hypotension, and they have hypotension.
Okay.
Bronchodilator.
Then you are intubated, right? You have still, what is the next slide? Go to the next slide. Next slide, please. Okay, next slide.
Next.
Here,
before this, yeah.
Yes.
Anyway, just before this, if he has, hence NIV support was given intermittently, and now we are just thinking about a case of you're intubated already. So how do you set the mechanical ventilation? What are the things you set, and why do you set, and how you're going to work about the pathophysiology, what is the mechanism it is going to work, how you're going to identify the whatever it is, autopeep and all, how you're going to set everything. Just tell me around in 5 to 10 sentences. So because in view of time, then we will ask if anything in between.
Volume control mode. I prefer volume control mode with the targeting of 6 to 8 ml per kg of tidal volume and
Give the
respiratory rate
reasons
around.
for everything, please.
Yes.
If you're setting anything, you have to substantiate with the reason.
Yes, sir. Volume control mode, we can achieve target volume, and initially patient will have this bronchospasm. Volume control will deliver defined tidal
So
volume.
what is you
and,
said? You said the reason for target volume achievement, you go this, right?
So in controlled mode of ventilation we use, sir, because to target low volume and give more time for expiration, it is the preferred method. And volume control mode is preferred because it has a sine wave flow pattern compared to the pressure control mode is a decelerating pattern. So in decelerating pattern, we will have more chance, more inspiration.
Yeah, that's correct. The decelerating pattern, right? And they are going to find,
and we target mean ventilation of less than 115 ml per kg body weight, tidal volume of 6 to 8 ml per kg body weight, IE ratio 1:3 minimum, and respirator of around 10 to 14.
What is the maximum IE ratio you normally put it? You can go up to
1:5. 1:5. If you give 10 respirator, can go up to 1:5. And respiratory flow rate of around 80 to 100.
Why do you want to go for that? Reason for respiratory rate is low and you're putting 1:3 ratio minimum and all. Why?
Sir, to prolong expiration, we keep IE ratio more, sir. And inspiratory flow is kept high because to cause inspiration at a faster rate and a shorter interval, and it helps in a more expiration time. And minimize the inspiratory and expiratory pause in between.
To decrease the airborne resistance,
yes,
to increase the duration of expiratory time, and to reduce the dynamic hyperinflation.
Yes.
So that you reduce the finally you reduce the autopeep.
Autopeeps.
Okay. What are the types of autopeeps? You have static and dynamic, right?
Yes, sir.
Okay. How do you assess the autopeep patients?
So, end expiratory hold for 3 to 4 seconds. We will assess in control mode. We will assess the autopeep. In flow time scalar also, inspiration begins before the expiration, and flow volume loops, that volume ends at the
Tell me 4 things, like how do you assess the autopeep and which loop and how?
So
Yeah,
flow volume.
Go ahead.
Yes, sir. So flow volume loop, sir. In flow volume loop, volume touches the y-axis. It doesn't touch the 0 point. It touches y-axis, and
it never reaches the baseline.
yes, now it is a baseline. And
like your ventilator doesn't have a loop and scalar. How you will say?
Sir?
Yeah, you have now advanced ventilators are available, but Vijai Kumar sir, when he started practice, there was no loops and curves.
Yes,
Scalars.
Flow time scalars.
Sir, we like to call it as a curves.
Inspiration begins before it doesn't touch the baseline. So before expiration doesn't touching the baseline, inspiration will start in the flow time. In pressure time also, we can see that expiration will end above the set peak, that pressure time scalar. And
we talked about the drugs to be given at the time of intubation, and we said rapid sequence, etc. Another important thing is the size of the ET tube.
Very important.
Larger
all our, this inspiratory time and IE ratio, all these things get different if the ET tube is smaller. If you are putting something like 6.5, then you are not going to achieve all these. You need to go for the biggest for that particular patient. It could be 8 or 8.5 rapid sequence. And weaning becomes easy, especially if you have a larger ET tube.
Not only that, as the pathophysiology itself is resistance itself is going to be improved, no, with the size of the tube, and also useful for the doing a bronchoscopy and doing the ball and doing that. Okay. And as you were talking about, sir, finish that, Vijay Kumar, sir?
Yeah.
As we were talking about a static and dynamic, what is the difference of the static and dynamic autopsy? Value is accurate in static, whereas a value is less and not accurate in dynamic, and that too because of the inadequate expression and time constant. Okay. Next. Okay, go for a previous slide.
Just previous slide. Yeah, I agree with the last 2 lines, which are okay. But as far as the meter dose inhaler is concerned, we have to go for the latest glycopyrronium LAMA, and also the latest LABA, that is formoterol. And depending upon the severity of the COPD, you may add budesonide or you may not add budesonide. And incentive spirometry is to be avoided because it promotes air turning. So do not advise incentive spirometry for your COPD patients. In place of incentive spirometry, you can advise them PAP therapy, positive airway pressure therapy. We have Aerobica, and then we have other devices which will promote expectoration. A patient can bring the mucus out of the lungs into the throat and then he can spit it out. So PAP therapy is advised. Incentive spirometry is to be discouraged. This is my last take.
As your intubated patients and doing well and in a control board, increased inspirator time, right? Why do you do that? Which is a ventilator change you do once you get the ABG again?
Sir, can you repeat the question, sir?
No. Like in ventilator patients, like nebulization you give or after that ventilator patient, after few, as Vijay Kumar sir asked you do the ABG, and again when you want, what are the things you look for mainly? In asthma and COPD, how do you change it? What are the ventilator changes you mainly focus on?
We'll look for the pH and CO2 values, sir. And
Dynamic
PO2
hyperinflation.
values. This based upon the PSCO2 values, we will change the ventilator settings. If there is no significant improvement in PSCO2, we have to decrease the respiratory rate and increase the IE ratio.
You give nebulization when the patient is on ventilator. What is the best method?
We can give, sir.
Yeah.
Ultrasonic.
What changes you put in the ventilator? Like you were talking about, no? What do you do?
First, we have to remove the humidified devices, humidifiers first.
Number one. Next.
And it has to be in the inspiratory limb.
Okay.
And
And
near to the patient.
Better drug going on, what do you do?
It has to be near to the patient.
Limb, you put, yeah, fine. Then
it has to be near to the
you put the patient in control mode. Then
and more tidal, large tidal volume we have to give, and more
inspirated time.
Inspirated time and large tidal volumes.
Yes. Okay.
You can also use meter-dose inhalers in place of nebulizers. So we can keep the inhaler canister in the circuit, and we can give it about 5 to 8 pressings, 5 to 8 actuations are equal to 1 nebulization. So you can use that also. There are studies which said that meter-dose inhalers are equally as good as the nebulization. There was a question from Dr. Venkat. The differences between COPD and asthma in this scenario. Asthma patients actually don't require NIV for a very long time. The role of NIV in asthma, acute severe asthma, is only in the casualty, in the emergency, as soon as the patient arrives, so that within the next 2 to 4 hours, the NIV is used, and quickly to decide whether the patient requires hospitalization or not. Many patients who come with acute severe asthma who are given NIV, who are also given in IV steroids, they get better. Also bronchodilators, they get better and they may not require any admission. Unlike COPD patients, they go home. Whereas COPD patients, since it is a very long-standing pathology, they have to be in the ICU, they have to be in the hospital, they have to be admitted. The role of IV steroids is more important in asthma. And the role of antibiotics is less important in asthma, whereas in COPD, steroids are required, antibiotics are required. Whereas patients who have acute severe asthma, they give a history that they have been okay before the exacerbation. They have been going around, they were going to the supermarket to buy things, they were driving their cars, etc. So we have to look for some trigger which has worsened their asthma, so that you will get it in the history. And COPD, as a rule, most of them are definite smokers. Either they quit smoking very recently, or they are current smokers. But history of smoking is definitely there. And then you have what is known as the pack years. 20 cigarettes is 1 packet into number of years. If somebody is smoking for 30 years, 20 cigarettes, so 1 packet into 30, that is 30 pack years. Most Indian packets have got only 10 cigarettes. So you have to make it as 0.5. Whereas abroad, most cigarette packets are 20 cigarettes. So there's a difference. And we get many people who smoke BDs. Some BDs have got 22 BD kattas, have got 22, 24, 25, like that. So since it is difficult to calculate the pack years, we calculate the smoking index, number of BDs into years. So there is a question, any studies regarding steroids? With relation to asthma, yes, steroids have to be given intravenously. It takes 4 hours for the steroids to work. So we have to keep the patient in the casualty at least for 4 hours. And in the meantime, give him NIV and oxygen. And you can also give them a mild psychotropic drugs like haloperidol to reduce the anxiety. Clonazepam also has been found to be reasonably safe in small doses, 0.25 to 0.5 mg SOS.
As in view of time, Anudeep and Ganesh, you have been using ultrasound in your ICUs, right?
Yes, sir.
So have you seen any, it's not that every patient you can easily win off the patient on ventilator, not very easy, right? So have you noticed any time like pulmonary edema, weaning induced pulmonary edema?
Yes, sir, we have.
Oh, nice. So how do you assess and what is the treatment? Just for the completion sake, Vijay Kumar sir, because anyway, as a senior pulmonologist,
time is not a limit, sir. I think all our students are encouraged to hang around as long as you both can stretch your wisdom.
Yeah, I request permission of Dr. Venkat and Dr. Mohan to leave in the next 1 or 2 minutes because there's something else waiting for me.
Sure. Just 2 minutes, sir. Over. Last question. Yeah. So,
sir,
yeah, tell me, doctor.
Because of heart-lung interactions, usually when the patient is on ventilator with the pressure control mode or any control mode.
Anyway, we do SBT for every patient for a weaning trial, right? Spontaneous breathing.
Yes, sir.
Okay, yes, then you are failure in that. Then you have a pulmonary edema, you have noticed.
Yes, sir.
So what do you see?
B lines, sir. B lines.
Okay. So whenever after 1 hour of the weaning, you should see, right?
Immediately also.
Yeah. You will get, normally you get it immediately. Yeah.
Sir.
And you look for the pre and post weaning, and you also, you can do NT-pro BNP, right?
Yes, sir.
How do you treat?
Pulmonary.
Distribution to NIV and use of diuretics.
Yeah, fine.
Diuretics
Keep in
and
negative
allopurinol.
balance. Keep the patient in negative balance.
Okay.
Yeah, one thing is we talked about the antibiotics. Procalcitonin also will help us to guide the use of antibiotics. Procalcitonin are
To
high.
wean the antibiotic, CRP for to use the antibiotic, because procalcitonin is to wean the antibiotic, CRP is to use the antibiotic. Anyway, so as you said, you're talking about diuretics you are giving, and you are giving the looking at the ultrasound because the preload is high. If it is afterload is high, what do you do?
Vasodilator, sir. NTG can be.
Good, very good.
Somebody
Yeah,
asked
then-
about the derifylin. We stopped using derifylin a long time back, but aminophylline was being used extensively in India, although Western literature have given a very strong caution about using aminophylline. But in the Indian hospitals, by the Indian pulmonologist, aminophylline is being used in certain cases. Only you must have sufficient experience in deciding. Very elderly age, it can produce tachyarrhythmias. Somebody using derifylin is not appropriate. Probably they have to read the literature and get updated.
Yeah, it's very fine. Vijay Kumar sir, as you said rightly, when the patient is still having a persistent and refractory bronchospasm.
Correct.
And what is the drugs they should use?
Yes.
They can tell, no?
Yes.
You can use
So,
aminophylline, sir. Oral 10 mg per kg body weight with a target serum levels of 5 to 12 nanograms per ml. We have to measure. We have to keep the target, sir. And we
Helios.
have to train the patients to use proper inhalers. How he is using.
It's a
and
refractory,
we should
no.
train
No.
Previous. No.
Sir is asking something else. What about
Helios.
magnesium sulfate?
Magnesium
Yeah,
sulfate,
yeah.
in bronchial asthma, we can try, sir. Bronchial asthma.
Aminophylline is
some role.
one, magnesium is second.
Mast cell stabilizers all have role in bronchial asthma compared to the COPD.
Yeah, we're talking about acute exacerbations.
Refractory spasm.
Refractory.
One more is Heliax, sir. Heliax.
Heliax,
Yeah,
you
yeah,
can use
yeah, true.
Heliax.
How it works.
If FiO2 less than 40%, we can try, sir. If the patient requires FiO2 less than 40%, we can try. And use of aminoglycos, azithromycin to 250 mg to 500 mg for 1 year. There's some evidence
Yeah,
that
at the
prevent
time of
exacerbations.
discharge.
At the time of this, to prevent exacerbations, we can try.
Any vaccination, sir, Vijay Kumar sir?
It has been mentioned, sir. Vaccination for pneumococcus and influenza
Yeah,
after complete recovery.
yeah,
At the time of discharge, both vaccines can be given at the same time.
yeah.
And usually pneumococcal vaccine is good enough for 5 years, and influenza vaccine to be given every year in the same month. And yeah, that's it.
Thank you, Dr. Anudeep and Dr. Ganesh. Thank you for your, both of you, for your presentation and excellent question and answers.
Thank you, Dr. Mohan, Maharaj ji. Thank you, Dr. Venkat. It was a pleasure to be part of this exercise.
It's
Thank you, sir. Thank
Thank you,
you.
sir.
Thank you,
pleasure.
both of
Thank you
you.
for giving me an opportunity. Vijay Kumar sir, nice meeting.
Thank you. Thank you.
Thank you.
Thank you, Dr. Kola and Shashidhar.
We will conclude the sessions, sir. I think everything was covered properly, and more practical points were discussed in the session. Thank you both. Thank both of you for giving your valuable time, sir. And thank you, Anudeep and Ganesh, for getting
Thank
a
you.
good case for discussion.
Thank you.
We'll close the session. Pawan.